Welcome to the Senior Moment. This is Connie Clark with Home Helpers, and today in the studio with me I have Vickie Nostrant. She is with North Idaho Home Health, and we're going to talk about a couple of different things today, but the first thing we're going to talk about is balance. One of the big issues with seniors and anybody really is falls. You really don't want someone to fall, especially if they're a senior, because once that happens and they're injured, then you get the domino effect of things happening medically, emotionally, that sort of thing. So you really want to keep someone from falling. And North Idaho Home Health has a balance screening program that they've been doing, I guess, for a while. To help screen people that might have balance issues and identify them so that they don't fall. So welcome, Vickie.
Thank you very much for having me.
So tell me, what is this program? Do you just show up at someone's house to do it, or tell me about it?
The program that we have initiated at North Idaho Home Health is called Beyond Balance, and it's throughout the country, all of our sister facilities as well. And you have to be referred for home health services.
So a doctor has to write it.
A doctor has to write a referral for us to come in, either nursing or therapies or both.
Okay.
And once we're in the home, every patient that we have on our service gets screened through this Beyond Balance program.
Okay. And so if I'm there for speech therapy, you're still going to do the screening, correct?
Yes, and
Okay.
that's because a nurse, an RN, always has to open, and what that means is they have to go in first to get the process going for a speech therapist. And so the RN will screen their part of the Beyond Balance program, and then the beauty of this program is if they identify something that they believe physical therapy can help with, then they can call a doctor and ask if that's a possibility. If it's strictly speech therapy, it will be screened at a very minimal level by the nurse.
Okay. So do you just watch somebody walk, or what do you do when you screen someone for balance? Tell me the process.
It's an all-encompassing, holistic approach. We take a lot of history. We look at all medications that patients have, because medications are a big factor in balance issues. We also do hands-on. We check blood pressures, we check vital signs, we assess cardiac status, all of the things that can go into balance issues. We particularly hone in on diabetic patients who have neuropathies of their extremities, and we do testing of the soles of the feet to see if they have good, what we call proprioception, whether they can feel what we're touching, if there's deficiencies on the soles of the feet, because that's part of your balance. If you can't feel where your feet are touching and what they're touching, then that creates the potential for falls.
So you're saying that if you can't feel something on the bottom of your foot, that's going to cause you to fall, even if you have shoes on?
Absolutely. I mean, shoes help, absolutely. We always encourage diabetics to wear their shoes because it is a stabilizing factor. But there's still balance issues, If there's not sensation on the balls of your feet, that's the thing that touches the floor first, correct?
Okay.
And if you don't have a good sense of what you're doing there, it can be a backwards, forwards, it can be side to side issue with lack of balance.
So not having these issues, I'm trying to understand. So if I'm a diabetic and I don't have sensation on the bottom of my foot, if I step on a dog bone, I can't feel that I'm stepping on a dog bone?
I'm sure there's all degrees of that answer.
But the answer could be no.
The answer could be no. You can't tell if you're tipping.
And that's what I'm thinking. A dog bone would make your foot not go flat, so it would go off to the side.
Exactly.
Okay. So you check the sensation on the bottom of someone's foot. If someone doesn't have feeling on the bottom of their foot, would they then be a fall risk?
Yes, because that affects their balance.
Okay. What would you do if you didn't have that feeling? How could you compensate that?
Well, we encourage again all folks to wear shoes. That so many of the elderly wear slippers, socks,
Mm-hmm.
and that provides no support, none whatsoever. So shoes are a big encouragement. Assistive devices in the form of canes or walkers, if you have neuropathies. But neuropathies don't go away. Neuropathies progressively get worse. So, if you're non-compliant or not wanting to or refuse to use those devices, you increase your chances.
What else do you all check besides the sensation on the bottom of the foot?
Again, we check all of the vital signs, particularly the blood pressures, and we check it from a sitting to a standing position. And if it's much lower in the process of getting up to that standing position, that's called orthostatic hypotension, low blood pressure, and it can happen, and it's related to diet, dehydration. So we check that to see if some meds could perhaps create hypotension. And so we check blood pressure and vital signs. We assess your cardiac status, maybe some cardiac irregularities that have cropped up or unknown that could create hypotension. And then there's just the fact of the physical strength. And any therapist or nurse will do an initial simple test called a tug test, and it's called a timed up and go test. And there's parameters that you would expect a person who is able to get up and around to be able to go 10 feet in a certain amount of time. And if it's lengthy and it's prolonged, then that's another sign that perhaps they're a fall risk. We watch people, you said, do we observe? We watch people ambulate from point A to point B if they're touching furniture along the way and stabilizing themselves. If they wobble in that short jaunt, then obviously that's a sign as well. So all of those things.
So you check to see their physical ability, and their blood pressure and that sort of thing. And you were also telling me something before we started, something about their ears.
Your inner ear is the source of your balance. And if your eustachian tube and all of the things behind your eardrum are working effectively, you don't have balance issues. But many of the elderly do. And part of the reason is age. Part of it can be medication related. And yes, we do. They check for what we call vestibular balance. And if people say, "Oh, I'm dizzy," you hear that the room's spinning. That's pretty much a classic sign of true vertigo or vestibular imbalance. And so then the therapist, particularly, that's a therapist specific intervention. They work on this vestibular balance and how to make folks aware of what's going on and how to compensate for it.
So if you do feel the room spinning and you have an inner ear issue going on, there are things you can do to compensate for that?
Compensate, not cure it.
Right.
But people also get dizzy because of different things. And again, I will go back to meds. Meds can be a side effect. So we can trial and error changes in medications. But yes, they can provide exercises or different things that compensate for that vestibular imbalance.
Would something like that happen so that it came on so slowly that you wouldn't really realize that anything was different? Or having the inner ear problem, would that be an all of a sudden change for somebody?
No, it could be either. It could be insidious. I know my mother has inner ear problems, and she was miserable for many years, and I don't doubt that she's still miserable, but she's gotten used to it. So she knows, she probably is always aware of it, but she's learned to deal with it. And in her case, balance isn't a huge issue, but yes, it can be insidious.
Could something like that start from an ear infection or being sick and then cause inner ear problems?
Correct.
So it could be just that someone has an infection or something like that is causing the inner ear problems, and it's something that could be cured
Possibly.
with
Yes.
antibiotics or
Yes.
something like that. So if someone is feeling dizzy, what kind of things would you do to help them compensate for that?
Well, again, I will say that's a real therapist-specific intervention.
Okay.
I'm not truly knowing of what kind of exercises they give or what tips they give to help you compensate. I don't know.
But that would be something in the report that this person has a inner ear problem that we need to do some sort of therapy to work on.
If the therapist was not already ordered,
Uh-huh.
then the nurse could make note of that, yes, and contact and converse with the doctor and say, this is what I'm observing. I think that they would benefit from a therapist intervention and get the therapist
Okay.
coming in. And I've got some documentation here. When you're talking about vestibular related imbalance, you might have people who, when they turn their head very quickly,
It takes a while for the room to catch up.
Yes,
Okay.
exactly. When they turn quickly, they do lose their balance because of that. Most everybody has experienced that at some point. Fullness or pain in one ear, that could be the infection behind the eardrum. Ringing in the ears, that's another that might be
Tinnitus.
Mm-hmm. Or nausea. You know, if you're in real busy environments where your eyes are darting from subject to subject and you get nauseated, that's also one of the cues.
Really? Yeah, because when you were talking about your head turning, I remember as a child, you spin round and round and round, and then you stop, and the room kind of keeps going, and you like that. You laugh. You think it's funny. But as you get older, just simple movements make that happen. It's not funny anymore.
No, it's not. It's got to be miserable. I haven't experienced that since a kid. But
It was fun then. There are a lot of people who are at risk for falling. If we see somebody that we think one of our loved ones are at risk, what would we do? What should we do? Should we have them tell their doctor to have a test like this done, or?
Well, I definitely think that's the first thing is make the provider aware of it to see if they feel they may already know about it. They may be aware of why it's there. Excuse me. But if they feel like, they might benefit from this program, then they have to do the referral. But you have to make the provider aware.
And a lot of seniors might think, well, that's just part of being old. I can't walk around as good as I used to. The room is spinning, but it's spun for years, so I'm not going to be too concerned about it. When I walk, I hold on to things because I want to make sure I'm okay. They may not think that is anything unusual. That's just a part of aging. And that's not really the case.
Well, it is. I mean, that just comes with aging. However, it doesn't mean you have to fall.
Right. Okay.
So
I guess that's where I was.
Yeah, you're not going to eliminate the shuffling gait, the forward-leaning gait, the hanging on to furniture as you go through. That's instinct to protect yourself. However, you don't have to fall. You do not have to fall.
When your therapists go out there, do they look at the environment the person's living in to see if there's rugs and that sort of thing?
Absolutely. That's called a home safety eval, and that comes in part with their evaluation. And that big throw rug you just brought up, that's huge. People like to have their feet warm and have throw rugs around. You've lived with it for years. However, if you're elderly and you're developing some of these traits that we talked about, shuffling, forward-leaning, stumbling, dizziness, the throw rugs are a gotcha, big-time gotcha. And so we do our best to convince people to put the throw rugs away.
Now, because I remember my mom and her house and all of her little rugs all over the place. There are different kinds of rugs there. The ones that both sides are the same, their material, and those things are deadly. I mean, you step on them and you're gone. But then there's the ones with the rubber backing on the back. Is that a big difference, or is it any throw rug? Because the ones with the big backing are still higher that you could trip over, especially if you're shuffling.
Correct. If you're not picking up your feet and walking smartly like we normally do as adults, and you don't as you grow older, yes, you will trip. It is the nap in any carpet, any throw rug is going to present a different surface. And again, if you don't have that proprioception on the soles of your feet,
then you
could
don't
just
feel
slide right on through, and all of a sudden you've got your toe hooked under a throw rug and down you go.
Because a lot of people may think, oh, well, my rugs have plastic or rubber on the back, So, and they don't move, so they're okay. But like you said, when you're shuffling and you're not really picking up your feet, but what you said is interesting that your toe got hooked on one of the cords of the rug and you couldn't feel it. I didn't even think about that when we were talking about the sensation on the foot, that you couldn't feel if your foot got tangled, especially the rugs that have the little frilly ends,
Mm-hmm.
you know,
Mm-hmm.
you wouldn't be able to know that you got stuck.
Well, either that or you wouldn't know that there was an elevation difference. You wouldn't have that sensation. And, if you were dragging your foot or shuffling, you would hook your toe. You wouldn't know it, and boom, you could go down.
Very interesting. I hadn't even thought about that. Um, what other kinds of things do you look for when you come into someone's home um, that would potentially be a fall risk?
Clutter, narrow walkways. I mean, that's something we all have a tendency to do is keep stuff that is unnecessary, and hoarding is a big new buzzword around because there's television shows that are promoting hoarders, but it is a problem. You have to have adequate walkways, especially if you use an assistive device,
Like a
a
walker or something?
walker, and then two, um,
I often think about lighting. You
lighting is
know,
one. Yes.
a lot of people may put in lower wattage bulbs or may not turn on lights trying to save money. And if their vision is going when it's darker, then they really can't see. And if something's there in their path, they're not going to know it.
Correct.
So you all do a safety review of the home too. When you finish up the report, what do you do with the report that you make on the evaluation?
Depending on the circumstance, of course, we tell the patients we recommend this be done. We can't force anybody to do these recommendations, and there are a subset of people who won't. They're just determined. If they're people who are demented, which is another fall risk in itself, then usually there's a caregiver, a significant person, children,
Family member,
family
somebody.
member that we contact. We don't just leave it with a person who we know cognitively is not going to be able to apply what we're saying. So we follow through with that. We also send all of our recommendations. If there's huge issue, we're in discussions with the provider. If we run into a big roadblock about safety and non-compliance or nobody to help, or we call in our social worker. We have a medical social worker who will come out and make referrals to community resources such as yourself who might be able to offer some assistance.
Yeah, because falling is a big thing. Like I said, I've seen so many circumstances where someone is just borderline and they've fallen, and that starts a whole nother issue of things happening. So that's really neat that you guys are going out and doing these fall assessments. We're going to need to take a break, but I want to talk about some things going on in the medical community too that Vickie has some really neat information on. So we will be right back.
How do you know you're not being recorded?
It's still recording,
Oh.
but she'll chop it out.
Oh, I see. I see.
She comes back and it's amazing what they do with us nowadays. And she can tell when there's like a blank when we stop talking. She can see that and she goes in and listens, and that's what we're doing.
Another thing that we might, it's up to you, might want to get back to this program. This program has been shown statistically because
Okay.
it's been in place with other agencies
Okay.
and within our system that it does decrease falls. If it's done, they know now statistically it does
Okay.
decrease volumes
Yeah,
of falls.
I want to say that.
Hmm.
Okay. All right. Do you know by how much?
No,
Or okay.
I don't have that data.
Okay. Is there anything else you want me to bring up about that?
Um, Vertigo, physical strength, communication. The medication, that's a big part of that too. But I don't want them to be calling their doctors because I said so. That's not the way
Well,
to go
you
about
want to
it.
bring up the fact that what you should do is if you're feeling that you may be dizzy or something, to take a look at
If it's new, if there's something newly developed,
look at if
it's
your
probab-
medications have changed.
are
and
there new
see-
medications? And that's one of the things we go in for when people start new medications is to watch that for a while. And then I didn't talk about blood sugar levels.
Okay,
You know,
All right.
that's a biggie.
all right. Well,
And heart problems.
okay, so let's do blood sugar. Meds. Okay, blood sugar, new meds, stats or balls, and heart problems.
Heart problems.
Okay. Okay. And then after we talk about that, then we can start the conversation about
Do you think it'll be in the next set?
it might.
Okay, let me review this because
Okay.
I just read this today and I don't want to
Okay.
fumble bumble around
No,
with
you're
it.
good.
Find a definition. Oh, here we go. Let's see. Is there a highlighter over there anywhere?
How's that?
Okay, I think I'm good.
You good?
Mm-hmm.
And try to stay like this far away from this the microphone. And you can move it. It moves all over the place. So, okay. You ready? And we're back. Welcome back to the Senior Moment. Again, this is Connie Clark with Home Helpers. And I've got Vickie Nostrant with me with North Idaho Home Health. And we've been talking about their balance program, in that going in when they're already coming into someone's home and testing them, for lack of a better word, to see screening. Okay. Test is not a good word. Screening them to see if someone could be a fall risk. And one of the things we had mentioned earlier was medications. And during the break, Vickie, you had said that it would be if you had a new medication that you started seeing changes.
Yeah, usually if you've been on a medication and it's established for years and years, your chances of it promoting the side effects that would cause the dizziness, that would cause the imbalance, are slim to none. But if you're starting new meds, or if you've changed the dose of a med, then that's when it could be due to medications. Some of the big ones that cause dizziness are antihistamines and antidepressants and Thorazine, some of the benzodiazepines. So for home health purposes, and if your provider has changed or put a patient on a new med, nurses can come in and they can monitor how the new medication is affecting the patient. Is it creating side effects? Is it doing the desired outcome? And then there can be the constant communication with the doctor to either decrease it, discontinue it, depending upon how it's going, or just simply say, looks like it's doing well.
Okay. So if you've been on the same medication and the same dose for a while, that's probably not what's causing the dizziness. It's probably something else. But if you've been on something new or increased or decreased what you were taking, then that could be an indication. You'd also said something about blood sugar. that could have something to do with this?
Well, of course. Well, I guess not of course. Yes, you could. As I said, diabetics have this neuropathy of their extremities, particularly their feet, where they lose sensation. But along with being diabetic, your blood sugars can vacillate if you're not on a good uh, contained regime. And if your blood pressure, or excuse me, your blood sugars drop, that's one of the things that happens. You get hypotensive, you go down. So, if blood sugars are not being checked, or there's been a change in your diabetic status, which happens, diabetes is a progressive disease. And so, if you're not in tune to what's happening, you could potentially fall from a low blood sugar that you're unaware is happening.
So you really do need to monitor your blood sugar to see if it's, peaks and valleys and stuff, because the
Absolutely.
valleys could cause you to go down in a valley, so
That's
to speak.
absolutely true.
And you were also saying something about heart problems.
There's a number of different things. The heart, the heart is the center of the body, and it is the pump. But if you have arrhythmias, that means there's potentially, what the big one is, atrial fibrillation. And that is a very, very common diagnosis for the elderly.
Tell me what that is.
That's when the upper chambers of your heart do not pump effectively. If you will, the heart sounds the lub dub. That's the lub is the top chambers of the heart, the dub is the bottom chambers of the heart. And if they aren't pumping effectively, you don't get the blood circulating like you do when it's all in place. And so you can have pauses, just the different pauses of the rhythms too. And if you have pauses, that means blood isn't circulating as it should be into the system. And thus you may have a lacking blood flow to the brain.
Even just momentarily.
Just momentarily. That's a potential. That's why we're talking about cardiac problems. And if they're diagnosed, then they're usually on medication for that. But if it's something new, you won't know.
And it's not something like you're going to get a fever or something like that that's going to tell you that. It's just you having these little brief moments of dizziness.
Correct. Correct.
Interesting. Now, I know that these screenings have been going on for a while, not just here, but across the country. What kind of results have you all seen so far as falls are concerned?
I can't quote you numbers, but I do know the promotion of this program is because they have piloted it not only in my company and my agency, but in other agencies at similar programs, and they know it reduces the number of falls. So it is beneficial. It's been proven now.
So at least putting this out in the forefront of knowing, yes, someone is at a risk for falls because of whatever these reasons are, making them aware of it so that changes in habit, changes in environment can be made has actually helped
Correct.
keep people from falling.
Whatever the screening, training, interventions were, it has impacted the number of falls, yes.
And it could be any number of things from medically to your environment,
Correct.
to those changes. Very interesting. So again, if you have a loved one who you feel might be at risk for a fall and they're having someone come out to do therapies or a nurse or something, be sure to ask about if they're doing some kind of screening as a fall risk, because that is something very important. But before we got started talking, I want to go into a different direction here. One of the things that you and I were talking about was we were talking about home health coming out. And in order for home health to come into someone's home, it has to be an order by a physician. And in the past, they would come out, and if you were not showing any progress, correct me if I'm wrong, if you were not getting better, then Medicare and them would stop the visits because they weren't getting any results. Is that the way it was?
Correct. For as long as home health has been in place, there's been variations of this, but the criteria we need to be able to come into a home with a physician's referral is the patient has to be homebound. Homebound descriptions are pretty nebulous, but basically it amounts to the person cannot go outside the home without significant effort, assistance, or can't leave the home at all.
Okay.
And that stands regardless. People have to be homebound. The second thing that we have to meet is a skilled need, meaning that a nurse or a therapist, those are skills, there has to be a need for it. It can't be something that can be provided by non-skilled agencies such as yourself. You do a valuable service in helping people stay in their homes, but you're not offering skilled
Right.
services, you're offering home care services.
Right.
And the third thing is,
That you have to be getting better, right?
yes, I'm sorry, I dropped it. And you have to be able to show improvement.
Okay.
If the patient is, or historically, if the patient has a disease or a lack of willingness to work with us and work with the recommendations, then we can't stay. We have to get out. But that's changed.
Yeah, you were talking about that there was some sort of suit filed against
Yes, we just got
CMS.
We did. We just got. Understand, please, that Medicare is the biggest payer for elderly services in the country, and most every insurance or Medicare HMO, almost everybody is following suit with whatever Medicare dictates.
So whatever Medicare guidelines are for care, for if you have home health come in, whatever, the other insurance companies kind of follow those
suit,
guidelines.
yes.
Okay.
So, again, the Medicare folks, that's been our rules for home health. To come in, we had to meet those criteria. Well, there was a lawsuit that we were made aware of. It was in October of 12, and the U.S. Secretary of Health and Human Services and the Center for Medicare Advocacy did sue the CMS folks for groups of people who have chronic conditions that are not going to improve.
So give me first stop. Give me an example of a chronic condition.
Parkinson's disease,
Okay.
multiple sclerosis,
Okay.
ALS.
So those things that someone is diagnosed with this condition that is never going to go away.
Never going to go away.
Okay. All right.
Okay.
Just kind of throw that out there. Okay.
And there's many more that go
Right.
into that. But anyway, the Center for Advocacy sued and they won, and so now Medicare and the federal the backings have to change their rules, and the rules are going to be changed to allow us to come in, again, a skilled service, be that nursing or therapies, and do maintenance programs for these folks. And
And that's a really big deal because, you know, you've got folks with Parkinson's or something like this that need physical therapy. In order to be able to keep their limbs moving, they need physical therapy. And if they weren't getting any better, which their condition is not going to go away, then Medicare wouldn't pay for it.
correct. And they tended to fall through the cracks of care because we couldn't come in. They weren't. I don't want to go into other pieces of healthcare like rehab facilities. Not knowledgeable of that. But what has changed is prior it was a restorative focus, and the intent was to improve their ability to function. And then we could do the plans of care go forward. Now the maintenance focus of care is to prevent further loss of function. Now it will happen, but you know, if we can maintain folks in their home at whatever level we encounter, that's the goal. We still have to prove and meet the skilled need. For instance, if it can be provided by your folks, meaning standby assist to get to the bathroom. That's not a skilled service. That's
Okay.
something a wife, a spouse, a
Right.
child, a paid caregiver can do. So it has to be a skilled service, and we can determine that. Our folks, our clinicians can determine by the rules and regs that have been set out whether or not we can meet that maintenance need. We can do that through instruction, and as long as people are able to listen to that instruction and carry out the exercise or whatever they recommended, then we're good to continue that.
Do you, and I know this is something that has just recently happened, but do you foresee this being that you would have therapists still going out every week, every other week, or would it be something that, or could it be both? Something that a therapist would come in, tell someone how to do their exercises, or a family member, and then come back once a month or something like that to monitor their progress?
I believe it's any of those things.
Okay.
Again, we can instruct on exercise programs, and we could leave simply and say they've been instructed, but we don't know that it's being done. We
Right.
don't know that it's being done right or correctly. So then we should come back in intermittently, whatever that is, and check to see that it is being done. People are compliant with it. There's truly trying to meet the letter of the recommendation, or if they need a little more education, to make it better, then that's allowed now. But to just keep doing the same repetitive instruction without any application and or doing it with any intent to do it correctly, that's not gonna be
And,
allowed.
and I could see what you're talking about falling through the cracks because someone could come in and do, physical therapy with someone, show them this is what you should be doing, and then leave. And I could, you know, myself included, month, 2 months, 6 months down the road, I'm probably not going to be doing those anymore, simply because no one is there to keep me accountable. That's just me. But this way, you've got someone still coming in, checking on them to make sure they're doing the things they need to be doing.
And again, the disease processes I just identified, Parkinson's, the neurological disorders, multiple sclerosis, you plateau and you can maintain a certain level of activity, exercises for a while, but then there's going to be a deterioration. It is inevitable. So as we come back in these maintenance programs, if there's been a change in the condition of the patient, a change in their ability, then there's another exercise program. There's another
So you can
needs.
change what they're supposed
Well, yeah, that's maintaining their ability. It isn't to restore anything. It's to maintain whatever level of ability they're at.
Interesting. Well, I want to keep talking about this because it does affect a lot of people, that a lot of people have fallen through the cracks and they need to be aware of this. So we're going to continue this conversation, but we're going to take a break and we'll be right back.
Yeah, well, it's brand new, hot off the presses.
So, before I ask questions, what do you foresee if somebody is in that situation? Do they go to the doctor and say, okay, now I want a referral for home health because I can now qualify, or what?
Well, if they're astute enough to do that, yeah, yeah. I think that providers are going to be a degree of aware of this, but like it's going to fall, I believe, it's going to fall in the same um, kind of referral process that we've got even now. If they have a patient who's in the home that's not doing well for whatever reason, or they have a concern for whatever reason, they simply have to call us or send us a rapid referral that says, I want therapy to go in and evaluate and treat. That's broad based. We don't know we need to know, is it because they have MS? Do we need to know because they had a recent fall? Is it because they are just getting weaker post surgery? We have to have some identifying reason, but then we develop with the doctor's concurrence this plan of care.
Right.
So, if a patient in these instances of progressive diseases, call the doctor if they know that. But if they are getting worse, hopefully the provider is going to know enough to say, we now have a maintenance. I want you to go in and do an evaluation.
All right, I'm going to bring that up then, that they really do need to, and you tell me if I'm wrong, if they have one of these diseases, it's not going to go away. That they really do need to, and they feel that some sort of therapy would help, or no?
Well, I don't know. again, that's up to the individual. If there's some people who are very savvy. Some people, they accept it as the inevitability. They just kind of go along and they aren't going to know that they're going to benefit. They're not going to be knowledgeable of this. So,
So tell them to talk to their doctor about
yes.
this? Okay.
Yeah, yeah.
I was trying to think of the right way to. Okay.
There's some very smart healthcare recipients, but then there's some that just assume the doctor knows. And I don't want to say doctors won't know, but this is pretty new. It's gonna
Yeah.
take some time.
Okay. All right. Let's continue. And we're back. Welcome back to the Senior Moment. Again, this is Connie Clark with Home Helpers, and I'm talking with Vickie Nostrant. And we kind of started talking about their balance program, but then we got into something Vickie told me that just came about that I find very interesting, having to do with Medicare and actually now covering the maintenance, home health maintenance of someone with a progressive conditions such as MS, such as Parkinson's, such as Lou Gehrig's, that Medicare will now pay for this. They're coming out to have home health services. So let me ask you, Vickie, if someone has one of these progressive medical conditions that's not going to go away and that they've probably been denied home health services in the past because they weren't getting better, what would they do? What should they do?
Well, again, it all originates with the physicians. They are considered the captain of the ship. Okay, so they should contact their provider and make them aware, or at least ask them if home health services are possible. That's probably the most simple route to take, because if the doctor feels or sees reason to have us come out, we will go out and evaluate. And we can tell him about the maintenance program if it's applicable and if we can see meeting the skill. So, yes, contact your provider and say, I really feel like I need X and it's getting worse, and, whatever. It's got to come from the physician.
Okay. And because this is relatively new, your physician may or may not be aware of it.
Correct.
So just be aware of that. When you call, they may not know that this ruling came down. And it's not through any fault of them that they don't know, because, I don't really foresee it going across the wires for everyone to see and hear. But it's there now. And if it can help you feel better, feel more comfortable, maintain your situation, then I would go for it.
And just like now, prior to this court ruling, prior to the change, restorative versus maintenance, all physicians, if they get a request from from patients or their families, or if they know their patients and know there's been a decline, they simply call us or write us a referral that said, this person has multiple sclerosis, I need an evaluation by therapy, I need an evaluation by nursing. And then it's up to us to go out and develop with his or her concurrence a plan of care. So you don't have to be specific when you call your doctor. You can just say, I feel like I'm declining, this isn't going well. Again, you or your family. And if they want to, if they feel it's in order, they'll make the referral and it will just build from there. So, that's no different than it is now.
So you specifically don't have to say, well, if I had someone come in and I did this exercise, then I would feel better. You don't have to do that. You just have to say, I think that I'm declining and I need some assistance. And then you all would come out and do that thorough evaluation of them. They don't have to feel like they have to substantiate it.
No.
Specifically?
No, the patient doesn't have to know specifics, doesn't have to know about restorative versus maintenance. They just have to know that, I just can't get around like I used to. I had a recent fall, I'm stumbling more, I don't feel good, I'm dizzy, all of the aboves, and say, do you think it's in order for home health to come out and check me out? I mean, that's simply put, but then the doctors can just pass that on. This person is complaining of vertigo. This person has multiple sclerosis. and declining in function, I need an evaluation and develop a plan of care.
So it's not that complicated for you to ask for help.
Correct.
I think some people may be hesitant because they don't think it's covered by their insurance, or they don't think that it can help, and that's not really the case.
Everything, at least in our company, and I believe it's probably across the board for home health, every referral is screened for insurance coverage. And if there's co-pays involved or if there's an issue with coverage, you're notified either before we get there or as soon as we get there, so you can make an educated choice whether you want to continue if it's a money issue. If we go out and we don't find the skilled need that has to be there for maintenance as well as restorative care, then we can tell a doctor why. And it may not follow through. It may not be that we can provide what I'm telling you about, but we will come out and at least evaluate that.
I think that's a really big deal because, folks that have those specific conditions were probably going, well, what good is this to me? Because I'm not going to get rid of this disease, so that means I can't have anyone come out and do therapy with me. And I think that's really great that someone has stood up and went, you know what, this isn't right. And I think that these folks deserve to have the help they need.
Well, simply put, it is a benefit, this maintenance, skilled maintenance. It is a benefit that allows for coverage of skilled therapy professional services for patients at risk of decline without that skilled therapy intervention. That's as simple as I can put it.
Now, when did this ruling come about? Has it been within the past couple months or couple weeks?
The information we have is it was settled in October of 2012, so not very long.
Not
this
very
is
long.
fairly new for everybody.
And I'm really surprised that it hasn't been really publicized in the community for folks to know that, because we do have a lot of people suffering from those medical conditions, and they probably don't know that this is out there, and it's really important.
Well, that's why you're doing this service.
That's why we're doing this. Now, let's talk about a little bit about what home health is, because I think when we started our conversation, I took for granted that everybody knew all the different therapies that home health provides. So other than going out and doing the screening for balance, what other therapies does a skilled home health provider do?
We have, excuse me, we have these different disciplines. We have a registered nurse.
And that's for wound care and things
that's
like
for
that?
Wound care, diabetic care, IV infusions, if that's what's in order. That's probably the biggest. It's the most broad-based discipline. There's lots of things that nursing does. Med management, if you're put on new or changed medications, we can come in, as I told you previously, and we can monitor how you're doing, the side effects, if it's effective, not effective. We can do instruction on new disease diagnoses. If, that's a real weak point in our healthcare system is education. And so we can be that educator as to what's going on with you. The second discipline we offer is physical therapy, and that's something I think people are more aware of, for more specific interventions. We have occupational therapy that can come out and work with getting in your what we call activities of daily living, in your bathing, your eating, your walking, your ambulating. They can also do those home safety evaluations. They can get you assistive devices to help you attend to your activities of daily living.
So as an example, if you were, you fell and you broke your hip and now you finally made it back home, the way you go in and bathe, or the way you work around in your kitchen, or the way you dress is going to be a little different, because you may have some pain issues and that sort of thing. And you all in the occupational therapy show someone how to do that.
Along with, there's grabbers. If people can no longer bend over, there's grabbers that they can recommend, bath benches, toilet risers.
So these people, when could
They-
help you
they
figure out
make-
how to do those things.
They make all of those assessments and recommendations to the physician, yes.
Okay.
We also have speech therapy, which can do kind of a dual role. They can check people for swallow issues. If they've had a stroke and their swallow was affected, they can help beyond what was done in the hospital, evaluate your diet, how thin your liquids are. They can give you suggestions on how to avoid choking and aspirating, however is necessary. Again, if they've had a stroke and they're unable to get food to their mouth, there's apparatus that they can recommend. There's utensil assists. There's different things they can do. I'm really not totally knowledgeable of everything that involves. But the other thing that they work with is memory decline. If they can evaluate memory decline and see if it's a normal aging process, or if there's something else going on. They also can work in that realm with putting up reminders. They talk about calendars and clocks and notes and some of the things to help people in the home with their cognition.
So when you talk about speech therapy, you're just not talking about someone talking.
No.
It's everything having to do with like the neck and up, so to speak.
That's easy. Yeah, pretty simplistic, but yes.
Well,
That's okay. It's okay. I mean, because, again, I'm not real knowledgeable of everything that a speech therapist does, but it is centered around stroke victims and head things, yes. We also have social workers, masters of social work, that can come out and assist folks with community resources, accessing, getting some paperwork started if there's, if they're going to go into a VA, or if they're going to think they need to go for Medicaid. They're very knowledgeable of all of the resources that are available and can get you connected. And they also have the potential as a social work to be able to help you with grief issues. If that's the loss of a loved one, if that's a decline in your health. I mean, grief takes a lot of different manifestations, and they can help through some of those issues.
well, and if you've just been diagnosed with one of these conditions we were talking about earlier, there's going to be grief having to do with that. Oh my goodness, I've been diagnosed with
Exactly.
Parkinson's. Now, what does that mean for me?
Correct.
And that sort of thing.
And then lastly, as long as we have any of those skilled services that I just recited, the therapies or a nurse, we can also have a home health aide come in and offer assistance with bathing or activities of daily living, much the same as what you do, but it can be there under Medicare as long as a skilled service is in the home.
And
They can't do it alone.
And that's always a question that I get. Sometimes people will call Medicare and ask, someone coming into my home helping me with bathing, is that covered by Medicare? And depending on how you ask that question, the answer could be yes or no.
Correct.
So the answer is yes if skilled services are already being provided by a home health company. Yes, Medicare pays for that. But if skilled services are not being provided, then no, Medicare doesn't pay for that. And I've had a lot of people that have just, come back, well, they told me it was covered. Well, let's qualify covered. So that has always been an issue. Is it or is it not? And I'm glad you brought that up. Because
Only our home health services, aid services, are only available while a skilled intervention is in there, a skilled discipline.
and that is covered by Medicare.
That is covered by Medicare and some insurances.
Right.
Or in HMOs. It just depends on the specific plan.
Now, if someone wanted to ask you questions about the balance screening and that sort of thing, Vickie, how would someone get in contact with you?
Well, our agency's number, there's 2 nurses in the agency. I'm one of them, and the number is 208-667-7494, and you're welcome to call and ask questions about Beyond Balance. If there's therapists that happen to be there, and that would be purely coincidental, they could also answer your questions about Beyond Balance. We've all been trained in it, and we're all applying it to every new referral we get.
And if someone's there that can't answer, they'll always call you back,
Correct.
to give you answers. Well, thank you, Vickie, for coming on and explaining all of that.
You're very welcome.
Balance is a big, important issue for seniors. because I know you've seen it and I've seen it where when someone falls, again, that can start a whole domino effect of different things happening to them, that isn't always in a positive light. And so we really do need to keep our seniors safe. So thank you.
You're welcome.
And you've been listening to the Senior Moment, and I hope you have a wonderful rest of your weekend. Good day.